Assalamu alaikum. Good morning, everyone. And I would like to thank the organizing committee for inviting me to speak to you today. So I'm going to discuss the future look of ALL therapy with the incorporation of novel agents and CAR T cells. So stop moving. Which one? Flags behind. Okay. So the outcomes of ALL have improved over the last 4 decades, and the improvement was more pronounced in younger patients with ALL. Older patients with ALL, still the outcomes lags behind, and patients above the age of 40 have an overall survival at 5 years of less than 50%. The hyper-CVAD regimen, a common regimen in our area used for adult ALL, the outcomes at 5 years published by the MD Anderson showed an overall survival of 38%. And when they looked at the outcomes according to age, patients who are older than 40 had a 5-year overall survival of 30%, and patients above 60 had a 5-year overall survival of less than 20%. So first, I'm going to discuss how outcomes are improving in BALL and what's the future look like. So the addition of immunotherapy has actually improved the outcomes of adult Ph-negative ALL. First, with the addition of the anti-CD20 antibody agent rituximab ofatumumab, the antibody-drug conjugate against CD22 inotuzumab, and the bispecific antibody against CD19 blinatumomab. So this paper in JCO more than 15 years ago by the MD Anderson showed that the addition of rituximab to CD20 positive Ph negative ALL improved outcomes. That was a retrospective analysis. Subsequently, the French group did a randomized clinical trial with rituximab in CD20 positive patients, showed that the outcomes are improved with improvement in event-free survival, mainly because of the reduction of the cumulative incidence of relapse, 25% for rituximab versus 41% for the control arm. The bispecific T-cell engager, blinatumomab against CD19, have shown to improve overall survival in BLL. You are all aware about the E1910 trial. So the E1910 randomized patient who are MRD negative to receive blinatumomab 4 cycles with chemotherapy versus chemotherapy alone. And they added asparaginase for patients who are less than 55 years of age, and rituximab was also added in CD20 positive patients. So they showed that the 3-year overall survival was improved 85% versus 68%, mainly because of the reduction in the relapse death. This is the relapse-free survival for the E1910, showing a reduction, 50% reduction, relative risk reduction of relapse. And what was striking in that trial, that patients less than 55 years of age had a pronounced improvement in survival. You can look at survival exceeding 80% in those patients. So what about the addition of the antibody-drug conjugate inotuzumab to the upfront therapy? This was studied in the phase 3 Alliance trial that was presented in ASH 2024. So in that trial, they used a modified pediatric regimen, the 10403, and they randomized patients to receive either 2 cycles of ENO versus no ENO, followed by consolidation, interim maintenance, DI, and maintenance. That trial was actually negative. The 3-year event-free survival for ENO was similar to chemotherapy. The ENO arm had less progression and relapse. However, there were excess toxic death in the ENO arm, and that led to a similar overall survival between ENO versus control. So subsequently, they are doing a modification, the Alliance, on that trial. They're using 1 cycle only of inotuzumab, and they're adding 2 cycles of blinatumomab. in between consolidation and interim maintenance. So one cycle after consolidation and the other cycle after interim maintenance. So the MD Anderson are actually studying the modification of hyper-CVAD with the addition of blinatumomab with or without in younger patient with pH negative ALL. And this is the original protocol. So 4 cycles of hyper-CVAD with rituximab or ofatumumab in CD20 positive patient, followed by 4 cycles of blinatumomab consolidation, followed by shortened maintenance for 15 months with 12 months of bomb in between 3 cycles of blinatumomab. So the updated protocol, they have added also inotuzumab in cycle 2 and 4 of hyper-CVAD and cycle 2 and 4 of the consolidation blinatumomab. And inotuzumab is giving a fractionated dose 0.3 milligram per meter square on day 1 and day 8. So they had 75 patients treated, the initial cohort 38 patients, and the subsequent cohort 2 with inotuzumab 37 patients. So if you look at the responses, CR after induction, overall 84%, and MRD negativity after induction 66%. However, MRD negativity at any time approached 95%. with 0 early death. This is looking at the overall survival at 3 years in those 75 patients were 90%, and the outcomes were actually better with the addition of inotuzumab with relapse-free survival of 100%. However, longer follow-up is needed to see the sustainability of these outcomes. So the Golden Gate is a phase 3 clinical trial of blinatumomab with low-intensity chemotherapy versus chemotherapy, hyper-CVAD or GMAL-based chemotherapy. This is a phase 3 clinical trial, including patients above the age of 40 with pH-negative ALL, and they had the safety run-in with 10 patients, median age 69, and the CR was actually 100%. Now, the phase 3 clinical trial is ongoing, so blina with low-intensity chemotherapy versus chemotherapy. We expect the result in the upcoming years. So, inotuzumab, in combination with lower-intensity chemotherapy, mini-hyper-CVD, have been studied in older patients with ALL in this phase 2 trial by the MD Anderson. So they looked at the outcomes, 3-year overall survival was 56%. And the updated result, I'll show you the protocol first, then I'll show you the results. So the protocol is mini-hyper-CVD with inotuzumab fractionated, followed by, again, 4 cycles of blina, followed by shortened maintenance with blina and BOM. And this is the outcomes, long-term outcomes, 4-year overall survival, 50%. In a median age of 68, so quite older population cohort. And in their subgroup analysis, they showed that patients with high-risk cytogenetics had inferior outcomes. So when they did a propensity score analysis, they showed that the combination of mini-hyper-CVD, eno plus minus blina is actually superior to chemotherapy alone. The Alliance trial looked at chemo-free regimen in pH-negative ALL with combination of inotuzumab and blinatumomab without chemotherapy. So patients above 60 years of age with CD20 positive BALL will receive 2 cycles of inotuzumab, followed by 4 to 5 cycles of blinatumomab with intrathecal CNS prophylaxis. And the primary endpoint was 1-year event-free survival. So they had a total of 33 patients, and 8 of these 33 patients had prior cancer, and 6 patients of those had actually prior multiple myeloma. So they get inotuzumab induction followed by blinatumomab consolidation. And this is the outcomes. Composite CR after induction was 85%, and after blina was 97%. And if you look at the Kaplan-Meier curves for event-free survival, 74%, and overall survival of 84% at 1 year. They updated their data in the last ASH in oral presentation, and they looked at the 3-year event-free survival was 48%. They had some relapses. Some of them were CD19 negative, and some of them were CD19 positive. And they had no isolated CNS relapse, which is interesting for me. And this is the overall survival with Blina-Eno without chemotherapy at 3 years was 59% in this old population of patients with ALL. They showed that the CD22 expression impacted the outcome, so patients with less than 90% CD22 expression had lower event-free survival, and the best outcomes were patients who achieve MRD negativity after induction. So when they compared their data to the data from the MD Anderson, you can see that the overall survival is almost similar to the MD Anderson data. They had more relapses. However, the non-relapse mortality was lower with this approach. So something that is coming soon is the subcut blinatumomab, and it was tested in relapse refractory setting. In this data in 2 doses, 250, 500, and 500, 1,000. And this phase 1 trial looked at the CR/CRh, and they included patients with more than 50% blast. If you look at the CR/CRh, 86% for the 250, 500 dose, and 92% for the 500, 1,000 dose. So the toxicities are as expected in the relapse refractory setting with blinatumomab, including neurotoxicities and CRS. And patients were bridged to allogeneic bone marrow transplant after achieving remission. They expanded the data with this paper in the Lancet published last year, and they looked at the outcomes. If you compare the outcomes with the old Tower trial in the relapse refractory setting, it seems that the outcomes could be better actually the subcut blinatumomab. So there is a trial will start soon, and 5 centers from the kingdom are included in this trial. This is the subcut blinatumomab, newly diagnosed Ph negative ALL. We expect the study to start this year in the upfront therapy. So shifting gears to CAR T-cell, now we have 3 approved CAR T-cell products in relapse refractory ALL. We have the T-cell, obe-cel, and the Brexu-cel. And we expect the outcomes would improve with those agents. Now there is studies about optimization of lymphodepletion, studies about improving the manufacturer, and there are currently studies on bispecific CAR T-cell against CD19 and CD22. So there is a trial of using CAR T-cell in the upfront therapy, phase 2 trial called Cassiopeia. They looked at the use of T-cell in high-risk BLL who are end of consolidation MRD positive. So patients who had MRD more than 1% at the end of induction, they had leukapheresis. And if they are MRD positive at the end of consolidation, they received subsequent T-cell infusion. This is a trial by the COG, and the trial finished recruiting, and we expect the result in the near future. The group by the City of Hope and Dr. Ibrahim Iddos presented in ASH last year the CD19 CAR T-cell, their own product from City of Hope, as consolidation in older patient with BALL in CR1. So they had a patient who are more than 55 years of age with a CD19 positive BALL. They had 22 patients consented and actually 18 patients infused. So those patients, they got CAR T-cell therapy in the upfront setting. So a median age was 64 of the enrolled 18 patients. And You can see that there were no dose-limiting toxicity was observed. Only one patient had grade 1 CRS, no grade 2 CRS, and no any grade ICANN. And this is different from the relapse refractory setting. And with a median follow-up of 18 months, so 1.5 years, the median, the 1-year event-free survival was 94%, and the overall survival was 100%. So an interesting strategy for older patients with ALL is to avoid subsequent chemotherapy and give single CAR T-cell infusion. The MD Anderson is studying the obe-cel as consolidation in newly diagnosed patients with high-risk B-ALL, and this trial is currently recruiting. What about T-ALL, shifting gear to T-cell ALL? We know that the 0434 trial by the COG showed that nelarabine improves the outcome in T-cell ALL, and currently is standard of care in pediatric T-cell ALL. The subsequent COG trial studied the addition of bortezomib in T-ALL, and what they shown that in more than 800 patients, that the addition of bortezomib improved the outcome in T lymphoplastic lymphoma, not in T-ALL. So the MD Anderson studied the addition of 3 agents to hyper-CVAD in TLL. So, and initially, the first 2 cohort, they added nelarabine. Then in the 3rd cohort, they added asparaginase. And in the 4th and 5th cohort, they added venetoclax. So they're studying the outcomes according to protocol amendment over the years. So this is the final protocol they have. So this is regimen 5, the most updated one for T-ALL. So they had hyper-CVAD together with venetoclax in induction 4 cycles, followed by nelarabine with asparaginase, followed by 1 cycle of hyper-CVAD venetoclax, followed by 1 cycle of nelarabine asparaginase, and then 6 total of 8 cycles of hyper-CVAD with venetoclax. And this is followed by maintenance. It's a bit complicated protocol. So what they did with the venetoclax and the last regimen, they actually give less days in post-remission from cycle 2 to cycle 8, 3 days rather than 7 days. And this is the full cohort, so they had 145 patients. The original cohort, 96 patients, and the protocol with venetoclax had 49 patients. And if you look at the outcomes of the overall cohort, 5-year overall survival, 65% for 145 patients, and overall survival, 66%. And they have shown that the addition of venetoclax actually improved the outcomes in terms of progression-free survival. And there was a trend toward improvement of overall survival. However, this did not reach statistical significance. So daratumumab also is studied in pediatric relapse refractory ALL in the Delphines trial. And in this trial, they showed that the overall response rate in the pooled T-cell ALL in a 29 patient was 83%, more than 80%. And the upcoming COG trial is actually adding daratumumab to the therapy BFM nelarabine backbone. So we expect the results also in the upcoming years. So probably heard about this breakthrough therapy designation for a product called Sofi-cel. So what is this Sofi-cel? So this is a phase 1/2 trial of anti-CD7 allogenic CAR T-cell called 007 for patients with relapsed refractory T-cell malignancies. So what's this product? This is an allogenic CAR T-cell. So they get T-cell from healthy patients, and then they do CRISPR-Cas9 technology to delete CD7, so that to prevent killing from other T cells, and to delete the TCR alpha constant gene so they prevent significant GVHD. And then this product is expanded and infused to the patient. And in the phase 2 recommended dosing of 900 million, they had 13 patients, and the overall response in the 11 patients available was more than 90%. And 6 of those patients were bridged to allogeneic bone marrow transplant. So we expect probably the approval of this product in these patients. So in conclusion, I would like to say that ALL outcomes have significantly improved over the last few decades. Immunotherapy is an important component of the current upfront therapy of BALL. CD19 CAR T cell may soon be used in the upfront therapy of high-risk BALL, especially those who are MRD positive. Nelarabine, daratumumab, and venetoclax have all shown potentials to improve outcome in T-cell ALL patients, and we may soon see the first allogeneic CAR T-cell product approved in ALL. Thank you.